Next is Dr. Liz Lycett. Dr. Lycett is a board-certified gerontologist and the Geriatric Trauma Medical Director and the chair of the Department of Surgery, not surgery, that's me, Department of Geriatrics here at Boulder Community Health. Yeah, she said she's moving up fast. Dr. Lycett is passionate about providing evidence-based and patient-centric care and embraces a multidisciplinary approach to the care of seniors and their families. Dr. Lycett is originally from Vermont, and one time she saw Bernie Sanders in the airport.
Good afternoon. I'm just going to set a timer because I'm an internist at heart. I can talk all day. All right. I have 10 minutes today to give you, 10 minutes today to give you a snapshot of the things that are important in geriatrics. I'm going to give you one little clinical nugget. I'll do a little song and dance, and then we'll wrap up with some questions. So Last year, I was here for about 40 minutes, and we talked about the most common types of geriatric trauma. So just to start at the top of the funnel, as Ben Kynan mentioned earlier, 56% of our trauma patients are geriatric. 90% of that is fall from standing height. It's like the unsexiest kind of trauma. And a lot of that is osteoporotic fractures, so most of it. So I'm gonna focus a little bit on osteoporosis for about 5 minutes, and then we'll talk about geriatrics. So this slide is to remind us of how morbid and mortal and expensive this stuff is. So the National Osteoporosis Foundation suggests there's about 2 million osteoporotic fractures per year. That's a cost of about $26 billion a year. That's more than breast cancer. That is more than MIs. So this is a huge problem, and we all have a responsibility to work towards it. There's a lot of repetitive falls and fractures. So from Framingham, which was a longitudinal study, we know that a lot of recurrent offenders happen in the fracture realm. For those of us, I don't know how many are on the front lines, when we see a patient with a fall and a fracture, it is almost always osteoporosis. And the reason I'm hammering on that is because if we don't call it what it is, then we miss this opportunity to identify a problem and treat it, okay? So if you are the EMS that gets called to my house in January, this purple-haired hippie's on the ground. She fell coming out of the bathroom. This is my mother. She broke her hip. We talked about her hip fracture, her hip fracture, her hip fracture. We never said, you have osteoporosis. So this is a little catchy tune that some of us might have heard of. Does anyone know what NKOTB stands for? Thank you. I am 40, this is New Kids on the Block, and they have this catchy tune, what you gonna do about it, okay? So, give credit where credit is due. So I just wanna talk about the different places that care happens. So in the primary care setting, there are so many opportunities to identify and prevent problems. So it is our wheelhouse to think about how do we screen patients for fall risk. So this is something that is now done automatically on patients coming in. How do we review their medications and their medication side effects and risk profiles? Because falls so often are caused by medications and the things that we do to help people, okay? This might be thinking about exercise and prevention and counseling, thinking about healthy lifestyles. So there's a huge burden on primary care as the preventative aspect of things. I already mentioned when you're the frontline EMS people and you get called to those houses, my request of those people is maybe right before you push the fentanyl, you say, hey, that med list is 2 pages long. Maybe when all this is sorted, you could talk to your primary care doctor about limiting your drugs. If we all kind of comment on these things and think about it as a system, we all have a chance to help out. There's a data point for women. Most of these fractures are in women. Less than a quarter of the patients that show up with an osteoporotic fracture get a DEXA scan or a treatment. And when I talked about $26 billion a year, that seems like a huge lost opportunity. So when I'm thinking about how do we as a system look at this stuff, identifying the problem and treating it, okay? Let me go, here we go. So if we think about the people in the hospital, this is the trauma team, this is orthopedics, this is physical therapy, nursing, social workers that are working on discharge. It really is the entire system's responsibility to call it what it is and follow it up, right? So we've put some little things in checkboxes, like checking a vitamin D level, which is helpful as a baseline to make sure that someone else can treat this later. I sort of jokingly talk about counsel about limiting joy. That means less alcohol, that means no smoking, that means less caffeine. There's a sweet spot about exercise, because we really want more exercise for people, but the funny thing is there's a higher risk of repeat fractures in people that are highly active, so that seems not fair. Okay, so we need to think about the lifestyle stuff. Hopefully primary care is addressing it, but so should the hospital. When these patients come in for their 2-week follow-up or their physical therapy appointment, perhaps we should say, hey, did you know you have osteoporosis? Have you seen anyone for it? And there's a little plug down here on the bottom. There's so many people that can take care of osteoporosis. We just have to make sure it happens. We all do. This can be primary care, endocrine, rheumatology, geriatrics, because that's a new thing now, we'll talk. And then even orthopedics has a metabolic bone clinic. So it's all over the place, it's everyone's responsibility. I actually want to skip one slide just for funsies. I promise we'll come back to this. Those of us that are either of retirement age or thinking ahead about retirement, I want to do a show of hands. Does anyone worry about getting murdered? Oh, super, a couple. How about getting killed in a car accident? How about hip fractures? All right, okay. One more weird question. Has anyone heard of osteonecrosis of the jaw? A few. Okay, so here's why. This is the most fascinating thing I can come up with. This is a comparative diagram of the things that actually happen to people and how tiny osteonecrosis of the jaw is. And the reason this super obscure thing is on my slides is in primary care or anyone that has to treat osteoporosis, every single patient is so worried about having that side effect of the drugs. Which, where did they hear about this stuff? You're more likely to get struck by lightning and murdered, okay? So let me go back a second to treating osteoporosis. So if everyone in the system says osteoporosis is a problem and you should get treatment, the reason is because the return on investment is about 1 year. So if I put someone on Fosamax, it only takes about a year to start seeing benefit in fracture reduction, and it's about a 50% reduction in fractures. Not falls, but fractures. And that's huge because that might be the difference between independence or nursing home or assisted living. And when you hear that $26 billion, all those costs start to add up. Okay, so if anyone is worried about osteonecrosis of the jaw, stop and take your drugs, okay? Calcium and vitamin D are always important. I'll skip over the details, but those are things that we should think about. Here I am, like being pedantic to people that take 2 pages of medicines. Sometimes those medicines are calcium and vitamin D, so I have to be a little careful about reduction in meds. DEXA scans won't change whether we tell someone to take medicine or not. We still want them to get treated, but it kind of starts that conversation about ongoing care and management. The medications I've already talked about, it's a really important thing to talk about and act on because it's so preventable. It's not everyone, just like seatbelts don't prevent all death and demise from car accidents, but we sure as hell wear it every time, don't we? At least we better. It's about the same amount of reduction in harm if we wear a seatbelt as if we take a medicine for osteoporosis, okay? All right, back to my favorite slide ever. So I have 3 minutes left, and I want to give you a little bit of a snapshot on what geriatrics is within BCH. So I'm really happy to say we are officially launching a geriatric department. This started in February, and what that means is we are trying to build a little more resource for primary care and geriatrics. And that can be both consults, So let's say a patient that's been on the trauma service a few times, they've had 5 surgeries, their quality of life is diminishing, they're not quite sure what they want, but they need someone to have that talk with them. You could send that patient to us for a consult to think about what life looks like for them and where it's going. You could have them come to us for primary care. So if I have an old, frail person with geriatric syndromes, like high fall risk and dementia and too many drugs, medicines, that would be another person that we could see. And so we're trying to make ourselves as a resource for others so that we can get these patients the best care that they can have, and also help reduce some of the long-term bad outcomes that are expensive and difficult for all of us to take care of. Right now, I'm the medical director of myself and 1 nurse practitioner, but we have another doctor starting in July, and we have a 3rd physician starting, we hope, in the fall. He hasn't quite signed off on the line yet. So it's just to say this department is growing and it's important. It is not that everyone that is old, meaning older than 65, needs a geriatrician. They don't. But it is that when things get really complicated and it's not something that primary care is doing a great job handling, or you just need those complicated conversations where lifespan intersects with health span, those are the kinds of things that you might call us for, okay? I'm gonna stop there. I'll take questions if anyone has them. 10:21, sorry. Thank you, guys.